So we think about, we sometimes, we've seen slides that talk about eye allergy and histamine and all that. We've seen slides that talk about the role of T cells and where products like cyclosporine or lifitegrast fit in terms of T cell communication. We've talked about, so we've seen slides that show the mechanism of how steroids work. We've seen slides that show the arachidonic acid pathway, the cyclooxygenase pathway for non-steroidals, but I haven't seen one before that put everything together. And here it is. So if you think about, I'm short, but anyway, up here, let's say here we have T cells. We think of products like cyclosporine, topical lifitegrast. That's helping to mediate T cell activation or communication, depending which product you choose. We think of antihistamine products blocking mast cell degranulation. We think of topical steroids as acting on the phospholipase pathway, preventing the conversion to arachidonic acid, and the non-steroidals down here on the cyclooxygenase 2 pathway, which would help to block pain, of course, and help block formation of prostacyclins, prostaglandins, thromboxane, pro-inflammatory substances in their own right. Now, you think about it, it's a little funny because you sometimes give a patient an allergy drop, right? And they'll come back and they'll feel great. You sometimes give another patient the same allergy drop, they'll come back and say, I don't feel that much better. Why? There's a commercial on TV now for not an ocular product, but I think it's for a nasal product, where they say 6 is greater than 1, 6 is greater than 1. Well, here's the 6, right? I mean, some patients need more than just antihistamine in order right? I mean, some patients need more than that in order to have good comfort. How do we identify these patients? Hopefully we'll be able to tease that out a little bit here. And on a separate note, another talk we'll do on another day is going to have to do with allergy drops and the receptor profile affinity of different allergy drops. They're not all the same. And sometimes for different patients, it can make a difference, even though they're all in the same class, which product you choose. So on that day, we'll go through a little bit about the different receptors present on the surface of the eye, the signs and symptoms that you're going to notice and the patient's going to complain about, depending on what type of pathways are involved and which products best target that profile of condition.
Right, you're right, because there's no secret recipe for every single patient. Some patients with severe allergies will benefit from steroids because we see in the upper left, steroids will target the mast cells early on. But we also don't want to knock out leukotrienes if we're worrying about infection, in which case NSAIDs can work out. So a lot of times we may want to use a combination of all these drops.
And just last thing on this slide, there's a lot on this slide, that's why. Last thing I'm going to mention on this slide, in the old days, you had a non-steroidal Ocular, which, and you might remember as well, had an indication for allergy before it had an indication around cataract surgery, around pain and postoperative inflammation. And the reason that came to be was because during the studies, they noticed that versus placebo, when they gave the non-steroidal Ocular, well, there was a significant decrease in itching. It wasn't as good as the antihistamines, but it was much better than placebo. Once the topical antihistamines came into play, they outperformed this product, it fell by the wayside, and they took the same product and pursued a different indication and still exists in that space. So some patients still who have ocular allergy, and you think about it, if you have a cold or if you have sometimes even severe allergy, some of these products contain an antihistamine and a non-steroidal. So for some of these folks that have significant eye allergy, we have given them both an antihistamine and a non-steroidal, and they've done very well.
And then one thing we want to touch upon too are the triggers, mechanical, rubbing their eyes, whether it's an inflamed pterygium, pink macula, itchy eyes, if it's chemical or toxic because of preservatives and drops, if they've gotten cleaning solution in their eyes, if it's infectious, if they've had a really bad viral infection. All these things can create a lingering inflammation that can then lead on to dry eye down the line.
Sure.
And so lastly, also UV damage in the case of pterygium and pink maculas.
We should do one hour on this slide by itself. There's so much there.
All right, so now we have an understanding of how the tear film can change over time.